Thanks everyone for joining us today. I did send a link and a note in the chat. So at the end, please make sure you fill out the evaluation form, and we're automatically tracking attendance based on that. So in order to get the credit, you need to make sure you fill that out. Okay, thank you.
Hi, I just want to welcome everybody and say thank you for taking the time to hear what I have to say about addressing substance use. I do want to apologize. This isn't eligible for CMEs, and that is 100% my fault. I missed the deadline to get it submitted, so please don't blame TCN. Blame just 100% me because it's my fault, and hopefully we'll still get you'll still get a lot out of it even if it isn't reflected on paper. This morning, I think the presentation went well. I did use up every single minute available and kind of had to rush through the slides towards the end. So I'll be a little more brief as I just introduce myself as people continue trickling in. I am a prescriber in the Lawrence office in Massachusetts, which, if you don't know, is kind of an area with some economic disparity and deal with a lot of patients struggling with substance abuse. And before that, I was an emergency room nurse at Boston Medical Center, which, if you're not familiar, is along Methadone Mile. And I was there, starting in 2015 when we were still really coming to our culture of harm reduction and awareness and destigmatizing. But also as, fentanyl was coming to the market and Narcan was becoming more available. To bystanders and so on and so forth. So I saw a lot, as we would have emergency room patients come in with, really severe abscesses or cardiac issues or even like septic and then leave their emergency treatment because they would need to go address their substance use. Kind of sparked my interest in, how can we help with addiction and how can I play a better role in supporting these people that are really struggling. And I was there when we started dosing people with methadone in the emergency room so they wouldn't have to leave and they could just start their treatment right there. And while we're not discussing opiates a lot today, we're just going to focus more on the two more common substances of abuse, nicotine and alcohol. It seems like it makes sense, for this market to focus on what we're seeing more and in the interest of concision and kind of narrowed it down to that. I do want to point out the CARN certifications, the certified addictions registered nurse. When I was working at Boston Medical Center in the emergency room, I was seeing enough addiction medicine patients to seek and gain that certification as a test and a valid a verification validation of the experience that I had. It did just expire last month, but in my current role, I'm not seeing enough substance abuse patients to have renewed it. But if you hadn't heard of it, it's from the addiction nurses certification board or something. And if that's something that interests you, now you know it exists. So
Sorry to interrupt. I think we have a question.
Yeah, I don't have the chat up. I was
from Michael.
John, just to be clear, you're focusing on Massachusetts. You're not focusing on other areas, Washington State, West
no, this
Virginia.
is inclusive to everybody. I was just talking about where I've been.
Okay, I just want to make sure because I am a substance use provider out here.
Awesome.
And the fact that meth, heroin, fentanyl,
Yeah.
and as we are going towards Medicaid, Medicare clients over here in the West Coast, important to discuss because those issues are really really focused.
Yeah.
So it's just not just nicotine and alcohol. We're getting more of a spectrum.
Yeah. For
Out
sure.
here. So I'm going to make sure that it is covered, and then also talking about what is legal per state versus what is illegal per state.
Yeah, I think these are great points, and these are absolutely things that should be discussed. And I think there's probably an opportunity for you to present that stuff because the what I've done today in terms of the objectives we'll review in the interest of concision. We're going to talk about therapeutic modalities that are helpful for all substances. but the actual ins and outs of substances, in the interest of concision, because we only have an hour, that I used every single minute of when I presented this morning, um, we're focusing mostly on the tobacco and alcohol because they're the most common. But absolutely, and that's not even, I don't even think you mentioned other amphetamines besides meth, which we don't see a lot of meth up here. I mean, I could talk about this all day, but again, in the interest of concision, this presentation focuses mostly on the two most common, and then perhaps you could present something with your expertise and your knowledge, and then share your education, what you're seeing, and your advice about methamphetamines and stuff, because this is helpful information. But I only got 50 minutes or 59, 60 minutes of your time. So thought I would focus on what is most common by statistics and anecdotally in my experience and stuff. But that doesn't mean the therapeutic modalities aren't applicable to everything else.
No,
Yes,
that's
this is the same
really
presentation from this morning.
that's really helpful to know because the fact that you put in, and as they continue with these, to be that it's the individual's experience, not necessarily the collective's working through.
Good. So I will carry on. Can you guys still see the slides?
Yes, we can.
Awesome. So the training objectives are here. We'll define what substance use disorder. We'll go over the DSM criteria for the tobacco, alcohol, and we included cannabis too, since that's so prevalent. But the DSM contains the other substance use disorders if you wanted to dive into that. And then the neuroscience of all substance use disorders reviewed. We quantify the use of the tobacco and alcohol. We talk about the stages of change, and then we get into some therapeutic modalities and some pharmacotherapy. So the short answer of what substance use disorder is, continued use of a substance despite its negative consequences. And that can mean a myriad of things. And I think, to discuss tobacco use disorder, again, the most commonly abused substance, you could be a cigarette smoker and not necessarily have tobacco use disorder, right? You have to have at least two or three of these criterion. I do think it's pretty easy to meet some of these criterion when you consider, number 8, the substance use in situations where it is physically hazardous. It's always hazardous to smoke. We know it's well defined that it increases your risk of cancer. So pretty much everybody that's smoking right off the bat meets at least criterion 8. But then, as we're interviewing, getting to know our patients, developing this rapport, through our history taking and stuff, we'll kind of better understand what their relationship with nicotine is and tobacco, and do they have a loss of control? Are they persistently desiring and unsuccessful in stopping and quitting and so on and so forth? Are they craving the substance and so on and so forth? We'll take a deeper dive on the alcohol use disorder because they're all pretty kind of similar. You see there's 11 criterion for tobacco use disorder. There's another 11 for alcohol use disorder. And pointing out the first criteria, and I think too, probably doesn't need to be said, but you can be a casual drinker and not have alcohol use disorder. You can probably even be a daily drinker and not meet the criterion for alcohol use disorder. And anecdotally, we may have thought of an alcoholic as someone whose drinking has consequences, but that's not necessarily true. You can have you can meet the criteria for alcohol use disorder before your drinking has consequences in your life. But by that time, when you do have consequences, you lost a job, you got a DUI, you're losing relationships, so on and so forth. You're meeting a lot of these criteria, which are here or in the DSM for you to review. And then cannabis use disorder. In Massachusetts, cannabis just got legalized. It's becoming more and more available throughout the country. And I know it's not as well regulated here in terms of like the dispensaries. The potency is just not the same marijuana that was available 10, 15, 20 years ago. And as I talk to my patients and counsel them about marijuana, the ones, in their 30s, 40s that were smoking weed 10, 15 years ago. And when I acknowledge that, that they've changed marijuana so much, I usually say they've ruined it because they spend so much time helping patients with psychosis that comes from it or other negative side effects. they really light up and can kind of relate to that too. So, you know, as we're talking to patients that maybe have smoked marijuana forever, or you know, since their teens or 20s, and now they're in the 40s, 50s, and they're starting to see more consequences from it, helping them understand how much it has changed can really be helpful in helping them gain some insight as to what they're up against. With the new cannabis. So a little video here so I can get a drink of water about the neuroscience of substance use.
less dopamine. As a result, that person will feel the need to increase the amount of drug they take so that they can reach the level of high that they're used to. But it's not
So this is a nice, you know, reminder too that, you know, even though we're going to mostly talk about tobacco and alcohol here, you know, this applies to, you know, methamphetamine, amphetamine, Adderall, Ritalin, benzodiazepines. All of them are, you know, releasing dopamine and rewarding the patient and creating that tolerance and adaptation. I mean, pornography, internet, Snapchat, all these things that are available to us, gambling, the treatment modalities can just interchangeable words, you know. Dopamine, I think we've all heard of as that reward chemical that they just talked about. If you want to learn more about dopamine or just dive down a rabbit hole, Anna Lemke is an addiction medicine psychiatrist out of Stanford, and she wrote a book called Dopamine Nation or something along those lines, and she kind of shared her journey and her career and um, treating addiction and how she kind of had to dive into it. She's interviewed all over podcasts and stuff too. It's really fascinating stuff to learn more about. But the other key points about the neuroscience that the tolerance, we talked about is the more and more use is required to meet that same level of pleasure to kind of meet that. So then more and more time is spent or more and more resources from the person are going into that. And then adaptation, is how the brain's adapting to, and continue that substance and usually give up other things, which is awful for the patient. And then by the time they're coming to us or in counseling with us, we're really, having to retrain their brain to not be given so much to their addiction, whatever it is. So I thought it'd be helpful to kind of just review about tobacco that's inhaled into lungs and then into bloodstream. It's pretty rapid acting. It is a stimulant, which a lot of people don't realize. So when people think it calms them down, it's actually because it's a short acting stimulant. So they take a couple hits off their cigarette, it kind of gives them that rush, but then as they feel calmer as the nicotine's wearing off and they're a little more relaxed. So alcohol is absorbed through the GI tract or really any mucous membrane. I had pointed out earlier, I don't know if they're still doing it, but you've maybe heard of like they'll soak tampon in alcohol and put it in a mucous membrane and then absorbs through there. And that actually gets you more intoxicated quicker because when you ingest something through the GI tract through your stomach, it goes through the liver and the liver kind of metabolizes some of that out before it hits the bloodstream. But when you put it right in your mucous membranes, I mean, even if you held a shot of liquor in your mouth, you'd start to feel intoxicated even if you spit it right out without going because of the way it's absorbed there. So you feel the effects of that within a few minutes, and the peak effects is in 30 to 90 minutes, and the duration of the effect can vary depending on the consumption and how much. Originally thought I'd have more content about marijuana, but in the interest of concision, had narrowed things down, but I thought I'd leave it in here. The rapidity of onset for marijuana inhalation that's within the 30 seconds there immediately after consumption, and that can vary in terms of like strength and user and tolerance and so on. But the duration of the effects could be up to 8 hours, but usually less. And then marijuana ingestion is usually like edibles, can vary depending on how much food's in the stomach and the strength of the edible and the person. But you'll see the 30 to 60 minutes or up to 2 hours for onset. And sometimes, people that are used to smoking marijuana or ingesting it or inhaling it, when they try edibles, they don't get that immediate reward there. So then they'll take more edible to feel the effect, and then all the effect will happen at once, and they can really get walloped by marijuana to like a green out, if you've ever heard the term, where they're like so high they're really struggling to function. So tobacco, I did like to share the fun fact that nicotine is actually naturally occurring in tobacco leaves as a pesticide. It does to protect the plant. It's actually the same for caffeine. And I think sharing fun facts like that with patients is a nice way to like lighten the mood too. But when you realize you're like, for all the information that's out there about how bad for your tobacco is, you also realize that it's literally like a toxin to insects, help us realize the impact it has on us. So cigarettes, there's about 20 in a pack. If you don't know, if you've never bought a pack of cigarettes or smoked, and each one has about 1 milligram of nicotine. So the equivalency for chewing tobacco, the pouches are about 1/4 a pack each. If you don't know about pouches, it's something you put in between like your lip and your teeth, and it's absorbed through the mucosa there and gives you that little bit of a rush from the nicotine. But then you spit out the saliva because it'd be too caustic on your stomach there. And each pouch, I think I said, is 1/4 of a pack or 5 cigarettes or 5 milligrams of nicotine. Vaping is incredibly popular now. I had a patient I just talked to an hour or so ago, said, he was seeing people vaping like at a Yankees game he was at, and it's the heated nicotine extracted from the tobacco, and the strength and sizes vary. I mean, in the research for this, it was like watching a commercial for a cloud or some device with nicotine to be inhaled, and it was clearly marketed at like 25 and under. I was relieved to see that that one was actually illegal in the US. It doesn't mean it's not here, but at least we did something to kind of slow or prevent the use of this by those younger brains. So the vaping, it's like the flavors aren't legal. And I also realized too, I don't think I knew, because I could buy cigarettes at 18, that it's now 21. You have to be 21 to buy cigarettes. So the strength and sizes vary. So like a 5% is 50 milligrams per ml, a 2% is 20 milligrams per each milliliter, and 1% is 10 milligrams per each milliliter. So the tobacco usage case study is just reviewing to kind of apply what we had on that other slide there, that Alex, a 24-year-old Caucasian male, works as a courier for a local credit union, uses a vape pen throughout the day. He buys a new cart or cartridge, which is 2 milliliters of 2% nicotine every other day. So how much nicotine does he use? Well, the 2% is the 20 milligrams in ml, uses one a day, so 20 milligrams a day. It's the equivalent of a pack of cigarettes a day. And it's so helpful to help quantify it. I mean, smoking a pack of cigarettes is a lot of work to do that in every day. That's 20 cigarettes. And maybe there's a pack a day smoker on here, that realized that, that's realizing, it's about 5 minutes per each cigarette. I mean, how much time in your day is that you've got to get up, you got to go outside, get dressed, there's a lot of time and energy in that. But now with vaping, it's really easy to just hold your pen and not have an awareness of how much nicotine, a stimulant that could be contributing to anxiety and high blood pressure and other side effects, and you might not realize how much nicotine you're using if somebody doesn't help like quantify it for you. So alcohol, will kind of review the same thing. I think we've probably all seen the chart that just says the, liquor, wine, and beer. I mean, I like this chart, kind of dove in a little bit more because beer's varying so much, and like seltzers are varying so much, where some have 7 and 8% alcohol, and some beers are lighter. But just have an awareness that the quantity, that the percentage of the alcohol really contributes to how much they're consuming, because you can, I guess we'll review in a couple of case studies to see how much it can swing in one direction or the other. To determine the alcohol consumption, know the volume and percent of alcohol. You can't rely on your patient to tell you how many standard drinks they consume. So Samantha drinks a box of wine each week. How many standard equivalency drinks is it per day? I mean, there's no safe amount of drinking, right? I think, sometimes the Surgeon General will say, oh, 1 drink a night for women and 2 drinks a night for men. But I think they've kind of acknowledged finally, there's just not a safe amount. But helping patients understand how much they're drinking is one of those first steps in realizing, if or what the problem is. So ask. There's a slew of different kind of boxes of the wine in different sizes. So when you really hone in, well, what kind of box? What brand is it? What does it, look like? How big is it? And you can Google all this information. So she says she drinks a Bota box. Google what a Bota box is. They're 3 liters at 13.5%. 3 liters is about 100 ounces. 100 ounces divided by 5 ounces, which is a glass of wine. I mean, she's drinking about 20 drinks per week. She may not know she's drinking 3 drinks a day. She might just think that that's normal. If she's comparing herself to other friends or other people she sees at the liquor store, she might not at all realize that she has a problem. So Rainey drinks 3 Steel Reserve tall boys each night. So if you ask him, he might think he only drinks 3 beers a night. But we clarify what a tall boy is. A tall boy is 24 ounces. Some would consider a 16-ounce a tall boy, but his Steel Reserve is 8.1% alcohol, which is a malt beverage. So what he's thinking is 3 beers is actually each of those cans, 24 ounces, is 3 standard equivalency drinks. That actually seems wrong. 24 divided by, anyway. So he's actually drinking 9 standard equivalency drinks each night, and might not realize, how much he's drinking until we quantify it for him. So Megan drinks Megan drinks a fifth of Smirnoff vodka every other day. A fifth is a holdover term if you don't know, from when alcohol was measured in gallons. So it's equivalent to 750 milliliters or about 25.6 ounces. And I wanted to point out too, Smirnoff is one brand of vodka, but they have different labels. And red label is 80 proof, which is 40% alcohol, and blue label is 100 proof, which is 50% alcohol. So just that difference in the label is four more drinks in a week, because the higher ABV, the higher alcohol volume percentage means less to get to that standard drink. And then a nip is a small bottle with one drink. And if you don't know, a sleeve is 10 nips or 10 miniatures. I think the people that are drinking nips realize that each one is about a drink. Then I guess too, like Blue Label Smirnoff, which is 100 proof, would come in a miniature that's 1.5 ounces and would technically be a little bit more. I could probably spend, a whole hour or even maybe a whole day about marijuana. And, I think when we look back in 10 years at the legalization of marijuana, we're going to go, whoops. And I think, if we look at it objectively, we probably all have some patients that are really struggling with their anxiety, struggling with their depression, can't seem to get better. And, I think it's on us to help them gain that insight, and look more objectively at the facts and the information that it's there. I'll reference like Cheech and Chong for people that are old enough to know, and it's like, well, no wonder you're not motivated. Of course you're struggling to get out and do things. And I think, I hope that that video and that review kind of empowers us all to take a look at marijuana, that even though it's legal, doesn't necessarily mean it's safe. Alcohol has been legal. We all fully understand, that there's risks involved with that. And I know, as THC quantities are into 25, 35% versus the 2% it used to be, people are really struggling with marijuana. And I hope that we can, help them with that. So the trans theoretical model, I'll let him explain. So I imagine that was a review for most of us, if not all of us. But I reference this chart often if I have anyone with the DSM diagnosis for something, as I put the status of how they're doing with their alcohol use disorder, all contemplation, preparation, wherever they are in there. And this slide I originally had kind of like a, let's put the quote up and kind of guess, but it kind of got a little befuddled. So we'll make it a little easier, and the quote will just be right next to it. But a patient that states, I'm going to start attending support group meetings this week. They're obviously in the preparation phase. They've moved past pre-contemplation and are aware of their problem and are beginning to prepare. So they're in the preparation stage. The pre-contemplation stage is that, like, my loved ones are overreacting, everything is fine, I don't have a problem. So these are people that are still struggling with accepting or having that insight into their use disorder with whatever substance they're struggling with. And the maintenance phase, it'd say something like, I continue to attend support groups and therapy to help me stay on track. And that, like we talked about before in that neuroscience video, that adaptation there, this is their brains adapting now to a life of sobriety, and it's getting easier in that maintenance phase. And the action phase, there's still a lot of work they're doing. I'm actively participating in my addiction treatment program and attending weekly meetings. Contemplation, after the pre-contemplation, they're into contemplation. My drinking is really impacting life, especially work and family, and something has to change. And then the relapse or lapse phase is slipped up and drank again, but determined to get back on track. So I reference this often, and like I say, I'll update how patients are doing, just to kind of have a unified approach and definition of where they are and change. So some of the therapeutic modalities, we'll discuss the psychotherapy, the the Beck family and their CBT, of course, plays a role here, and motivational interviewing, I think, is probably the cornerstone of therapeutic interventions for any kind of substance use or change you're helping someone make. 12-step facilitation we'll touch on, behavioral treatment, contingency management, mutual self-help, clinic-based, online treatments. So cognitive therapy, we're supporting the patient learning how their negative emotions lead to their substance use, right? Like cognitive behavior, like what are your thought processes that lead you to do this, and then teach prevention strategies for questioning and changing thoughts. And then I thought it was important too to point out, hopefully we're discussing with the patient the plan for the therapy and confirming their consent, because I think we get in that like helping problem solving mode, and it's helpful to have the patient along for the ride, as we're going to change their thought process. They should be involved and aware and consenting to that change. Motivational interviewing, hopefully we're all familiar with and know a lot about, but useful to kind of review the rule mnemonic for our mindset, like the mindset that we should be in as we're helping our clients. And that's resisting the urge to tell patients what to do and allow them to create their own solutions. And I have a 4-year-old, so I get to do this a lot where I want to tell him, what to do, but it takes a lot more patience, but it works a lot better to allow them to create their own solutions, and or him to decide when he's ready to wash his hands, and or whatever task of the moment is. But understanding a patient's motivation will really help you. And I think doing so without judgment really makes a big difference. Hopefully, if this is a client you're seeing, a lot of their backstory, what they've been through, and that probably tells you're not able to fully understand what that's been like for them, whatever their background is or was, or is, or their perceptions of their background. So understanding and listening with empathy and not judging go a long way. And then empowering them to set achievable goals and overcome barriers. So it's like that cheerleader role that can go a long way. And I mean, for having a panel of only 250, 300 patients, I can name at least 5 people I've helped quit smoking by just month after month. Like, hey, you ready to quit? Oh, you'll quit when you're ready. And well, what do you like about smoking? Like, why do you smoke? And do you still enjoy it? And if you still enjoy it, then keep on keeping on. And that freedom to them helps them understand too that this is their show, and then they're more empowered to do it when they're ready, and it goes much more successfully than if I were to start saying, well, you need to be on Changix and you need to quit smoking, and that's just not how people work. I also think it's really helpful to review a typical day with the patient, asking open-ended questions and encouraging elaboration. Like, what's the first thing you do when you wake up? And then, when's your first cigarette of the day? Or like, when's your first drink of the day? When's how early in your day do you start looking for meth or whatever their substance is? And using that reflective listening where you're using their words back to them and getting the whole picture, not only creates that connection and that it shows them that you have that empathy, but they're already their words and reframing them back to them in ways that are helpful for them, seeing the extent of their problem or the opportunities for improvement in their substance use can go a long way to their recovery. But it all come down to their readiness to change, and we can't force them to be ready to change. We can provide them the education and that patience and that safe space, but resisting that urge to rush things goes a long way. 12-step facilitation, 12 steps, kind of synonymous with AA, and their AA focus is mostly on alcohol, but there's Narcotics Anonymous, and I think whatever your substance is, if you showed up in AA meeting, no one's gonna ask you to leave. You can apply what you're going through and use those steps if that's going to be something helpful to you. But it focuses on engagement and attending meetings and finding a sponsor. There's a strong emphasis on the abstinence from the substance. There's spiritual principles such as the honesty, faith, and acceptance. There's we'll go over what the actual steps are, but you build a support network. And that support network, as we're all social beings, goes a long way. If you've never heard of it, there was a 1989 movie about Bill W. Bill W. is the founder of AA, and it's a pretty good watch to kind of just give you some insight as to where it came and what his kind of mindset is. And there's a pretty famous quote in there, like, for all the work he's done and for his recovery and others, he's still says he misses drinking, and that's a symbol of like how how you just have to be powerless over alcohol, and that if you're somebody that's going to identify as an alcoholic, you're going to struggle. So I don't think we need to review each of the steps, but kind of know that in the beginning of the 12 steps, you're surrendering, and then confessing, and then maintaining, and people work through them at their own pace. I would say, if you're working with a client that's going through the steps, kind of review the steps around where they are, so you are familiar with the lingo and can understand better where they are and where they're going. Behavioral treatment, like contingency management, is based on positive reinforcement. I'm not suggesting by any means that anybody, working in outpatient mental health, like, create a contingency program and buy gift cards for their patient or anything, but we should know that these voucher-based programs exist and how they work, so we can guide our patients toward them. Or if, like, if a patient's parent or somebody, what can I do to help? And like, what can I do to support the patient? You can suggest things like that, and they can at least know that they exist. So voucher-based programs are based on behavioral principles that the behaviors are reinforced or rewarded are more likely to occur in the future. So examples are like gift cards for continued sobriety. It has shown that it increases the patient's self-esteem, their engagement in care, and their goal-oriented perspective. So if you think someone focuses so much on alcohol and like, when am I going to get my next drink, and where is it going to be, and how am I going to get it, and so on and so forth, like, you're giving them something out now. They can focus on how they can get a gift card, and what they can do to use those survival skills that they've developed for their addiction for something that's not their substance. Sadly, despite their efficacy, they're not widely adopted. And it's part of why I wanted to include it here, so we can just have that awareness to encourage the adoption of them. There's a link to a brief synopsis of a study from the APA that's helpful. So
We did-
mutual self.
We did have a question in the chat.
I'm going to get to that.
Asked,
Yep.
what
I'm going to get to
about?
that. I'm going to get to that in just a second.
Oh, okay.
So I thought that I'd just let it answer itself. Thank you for pointing that out there. So Alcoholics Anonymous, or AA, we talked about. I tell patients, if you don't like one meeting, try another. But I do think there is kind of that stigma, and that's probably going to be better for like the 50s, 60s. Like, I think when we picture an AA meeting, we're picturing, huddled around a box of old donuts and chain smoking in the back and jeans and stuff. So AA, I think Gen Z is really going to like struggle to benefit from or relate to, if it's, guys that are 50, 60, 70 that are, you have very different viewpoints, letting them know about SMART meetings, which is a more science-based approach, could be a better approach. So when you talk to your patient, do you go to AA meetings? Like, no, like I didn't really. Well, have them try a SMART meeting if they're younger. It's less churchy, it's less God-based, it's less faith-based, it's more evidence-based, but it's still a community. And that community can be really helpful for people that with any addictive behaviors. And then, yes, Valerie, I did see and was working my way there. The secular organizations for sobriety was mentioned in the book. I know very little about them and was disappointed that there isn't a lot of information. It seems like their website's down. I wonder if they still exist, or maybe there are more local chapters available and I just didn't see them. I didn't touch anything for volume. I wonder if, Martha, that's something on your end. Does anybody else have issues with volume? And Sam, your question about what kind of modalities can be helpful for denial, I think that's education and motivational interviewing. And that's kind of a broad question. There's a lot of denial, but using a patient's words and really sussing out and getting a good story and kind of reframing it back to them to help them see. But again, if it comes down to readiness and they're not ready to accept it, we just can bide our time and wait for them to be in that place. So clinic-based treatment, useful to know there's PHPs, like partial hospitalization programs. You probably all know that there's dual diagnosis or substance use, but usually like 8 to 2 Monday through Friday. They're particularly helpful for people in early recovery. I don't think anybody needs to go for like smoking cigarettes, but certainly for methamphetamine, heroin, so on and so forth, patients would benefit from a partial hospitalization because, different than like a residential program, they get to apply the things they're learning and working on that every night. Every afternoon they leave that program, they're driving by the liquor store and making that conscious choice to not stop in and buy a bottle. They're at the grocery store, trying to get a snack, and they're walking by the beer, and they're making that conscious decision to not buy a 6-pack. And then they come back the next day and they talk about their wins or their losses, because maybe they did relapse. And the PHP is usually 2, 3, maybe 4 weeks, depending on the person in the program, can be really helpful. And IOP is kind of a step down from that. It's usually like 3 or 4 hours in the afternoon, Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, something like that. And it is a nice segue. And some people, I've had patients be in IOPs for months, and they're there for them as they need. It's kind of some in-depth kind of group therapy. I have this slide on the online treatments. I think this will be better to review later. Just know that there's a ton of apps out there, especially as Gen Z is coming into fruition here, and not necessarily going to benefit from like AA meetings that the 50, 60, 70-year-olds going to benefit from. They're going to be on their phone. They're going to benefit probably from an app. I don't particularly know anything more than what's on this slide, but maybe narrow it down to like 1 or 2 for the patient and let them pick. Michael, I see your hand there. Did you have a question?
Can you talk a little bit about, I know you're focusing a lot on Gen Zs. Can you talk a little bit about the social economic disparities around substance use? So it sounds like a lot of the things is like, okay, you're doing private practice, we're going to send you to an outpatient. But what about if you're working with population that, let's say, is partially homeless or working
Yeah.
in the community? And how do we engage those individuals? I ask this because we are in the brinks of getting Medicaid, Medicare, and this
Yeah.
is something that's being seen with myself as a telehealth provider.
Yeah, no, I see a lot of Medicaid patients. Probably more than half my panels on, or Medicaid and Massachusetts Mass Health, and I think a humanistic approach is appropriate for everybody. You got to really meet people where they are and know about resources, and we can't expect the same thing for the six-figure income six-head white male that has all the resources available to them. So we, maybe, find what's going to be a more reasonable expectation. And maybe that's, using less of a substance, if that's what's helping them get through being unhoused or whatever they're struggling with. If they're, if you're a prescriber, I always, well, what are you treating? Why are you smoking marijuana? What does that help? I don't say why you're smoking it, but what's that help with? And knowing, if they're smoking marijuana because they have terrible nightmares, well, then I consider something like Prazosin to help with their nightmares, and I have a lot of success, with substituting whatever they're treating their medication, their substance with a medication that's appropriate for that. But I think a humanistic approach of meeting each person where they're at and tailoring your expectations or their expectations for what success is, to what they can actually attain, what they have the capacity for. And I think working with Medicaid patients is incredibly rewarding. And I'm excited for you, Michael. I think you're going to really get to help some people that really need it. And I'm excited to hear about how that goes for you.
Thank you. I
Right.
actually have 20 years of working with Medicaid, Medicare clients
Yeah.
starting at 9/11 who started with the substance use because a lot of them went through trauma.
Yeah. Yeah, trauma plays a big role in here for sure. So pharmacotherapy, we'll talk about smoking cessation and alcohol dependence. And Michael, I think you should be doing a presentation. You've got a lot of knowledge and a lot of experience, and I would love for that to be shared with everybody. So come on back. You could probably coordinate with Karen or Felicia to make that happen. We'd love to hear what you've learned in your 20 years doing this, and you can fill in the gaps that I've missed. So. Moving through the pharmacotherapy slides, we'll talk about the cytochrome P450 system. For those of you that aren't prescribers, it's basically the channels in the liver. There's different channels in the liver that metabolize different medications. And a lot of them have been identified. If you know about like gene site testing, the gene site testing identifies which of the channels the medication is metabolized in. But particularly important to when patients quit smoking, the hydrocarbons from the smoke induce the CYP1A2 channel, but the nicotine has no effect on it. So say someone goes from smoking a pack of cigarettes a day to wearing a nicotine patch, without those hydrocarbons inducing that CYP1A2, the metabolization of their clozapine, olanzapine, caffeine, Luvox, and tricyclic antibiotics is less, so the serum level increases. And I think it's particularly important, even if you're not a prescriber, to know, when your patients, oh, I'm anxious and I'm not sleeping and I quit smoking and I should just go back to quit smoking. Ask them about their caffeine. How much coffee? How many Red Bull? How many Mountain Dew? What's your caffeine intake like? And educate them, that the anxiety and the insomnia might not be from quitting smoking, but it might be from the caffeine that they're metabolizing differently. So nicotine patches. They're first-line treatment for patients who can quit on initiation. They're a nicotinic cholinergic receptor agonist. They kind of plug the hole that the nicotine was for those receptors there. It's metabolized through the liver, but also primarily, but also the kidney and lungs for regular smokers. And this is, why we went through those painstaking slides about like how much nicotine is in a vape and how much nicotine is in cigarettes and so on and so forth, because you determine the nicotine load. So, if they're not quite smoking a pack a day, then you wouldn't want to start them at 21 milligram a day patch. Or, if they're smoking the equivalent of 2 or 3 packs a day, you might start them on the patch, but you might you want to augment with like gum or lozenges. So it's going to be applied to a non-hairy, clean, dry skin in the upper body, and you rotate the sites. 6 weeks for the first patch, and then 2 weeks for each of the next 2 patches. You can lower the dose if it's not tolerated, or increase the dose for withdrawal symptoms. I personally have never prescribed like more than 1 patch. I would augment if somebody's coming down from like 50 milligrams a day. But it is safe to combine them for those that need it. The nicotine gum, also first line therapy for initiation, for those that can stop when the gum started. It may act as a substitute for the oral activity, so some people might do better with it, and the patient should completely stop smoking so they're not sick. But again, that nicotinic cholinergic receptor agonist plugs the hole. It's metabolized primarily through the liver. There are 2 strengths to it, so the lighter strength at 2 milligrams, for each piece of gum is about the equivalent of 2 cigarettes. I go through like the dosing and how to start and so on and so forth, but you should let them know too that the side effects, the headache, indigestion, nausea, hiccups, irritation of tongue, mouth, throat, etc. I talk about the nasal sprays, or I put the slide in here about the nasal spray and the Nicotrol inhaler. I think sometimes, resistance makes our brains do funny things, or makes our patients' brains do funny things. And, oh, well, I don't like the gum, I don't chew gum, and I don't like the lozenges, and what. So it's got to be the spray. I think having an awareness that the spray exists, and knowing how unrealistic it really is helpful education for our patients that might just be using that as an excuse, and maybe are going to like chase down. It's like, well, I'll quit when I can get the spray, and that's just maybe not really feasible. If a bottle costs $500 and insurance isn't going to pay for it, and then the Nicotrol, the inhaler, wasn't a sustainable business thing. It was, you'd have to puff continuously for 20 minutes. It cost over $500. So it's actually discontinued. It's still in the reference, but I thought I'd leave it in here for anybody that had heard of it, so more about like why I don't see it. But the nasal spray too, it does more closely replicate the plasma nicotine levels observed after smoking, but it is a lot. If they're a heavy smoker, they might use a lot of it, and that's not maybe sustainable. So pill form medications, varenicline or Chantix is the most effective tobacco cessation medications, and nicotine receptor partial agonist. So it mimics nicotine effects on the brain and reduces withdrawal symptoms. It blocks nicotine from binding to receptors and reducing reinforcement of smoking. So it kind of has that 2-prong effect there. It's mostly excreted unchanged with minimal liver metabolism. If they usually quit a week after they start. There is a starter pack, but I did put in there the sick line for prescribers, which I'm happy to copy and paste if that's helpful, or a barrier, because it's like, to someone prescribing it to know the sick line, and so the pharmacy doesn't call and say, oh, you wrote for this, but it's actually this, whatever. But if they don't quit in the first 12 weeks, it's probably not going to be successful, so I wouldn't continue it. But if they do, you might want to continue for another 12 weeks to help them maintain that quitting. It may lower the tolerance for alcohol, but histamine blockers, quinolones, and Bactrim, it may increase the levels of those. Still common side effects. Everyone talks about the dreams. It's really common, so I always give a heads up about the dreams. But nausea, insomnia, constipation, gassiness are also possible. And then important to share through this rare but serious risk for neuropsychiatric events, depression, SI, suicide, psychosis, hostility, and letting them know that those things might happen, so they're not blaming themselves and realizing that it's the medication to stop and try a different form of therapy. So Wellbutrin or Zyban or bupropion, which is Wellbutrin, but they rebranded it as Zyban. It's less effective than varenicline, but it's a good option for comorbid depression, as it is a stimulating antidepressant, or if they're worried about weight gain, because it's also used for weight loss and appetite suppression. since it's a norepinephrine and dopamine reuptake inhibitor, it does interrupt that reward pathway, but can also, lead to anxiety and irritability and stuff. So the target quit date's usually the second week of treatment. They have this weird sustained release dosing. You could probably just do the regular XL that you would start anybody with depression on. But if they're not successful after 7 weeks, consider discontinuing, or the literature says to consider discontinuing because it's unlikely to change, but you can continue past the 12 weeks based on risk or benefits. It's effective for about 25% of patients, whether or not they use a nicotine replacement therapy. Naltrexone is a first-line medication for alcohol use disorder. Well, it's an opioid antagonist. It reduces the endorphin-mediated euphoria from drinking. While it's pretty toxic there's a risk of liver injury. Drinking is too, right? So you can weigh that risk benefits for patients. Patients that are drinking through it should definitely not be taking it. But since it makes the drink less rewarding, it can be really helpful. And, especially somebody that's like, well, when I drink, I only drink 10 drinks. They just can't stop themselves after they have one. There is literature that supports targeted oral therapy where, if they're not drinking every night, but if they know they're going to go out on Friday and drink 10 drinks, they can take it just on Friday night, and that might help them not drink the whole 10 drinks and keep them safer. But it does require the liver function test to be monitored. And since it, interrupts the reward pathway, it could be interrupting their joy from other things. They might be a little less excited to see their grandkids score a soccer goal or something. So it's always a risk benefits in conversation of what's going to be most beneficial to the patient, depending on where they are in their recovery. Antabuse, I think I've prescribed once to a patient that didn't even end up taking it. It's that, classic, medication we always talk about and learn about. That's the aversive treatment that'll make you really, 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 really sick if you drink, by keeping you from being able to break down the active metabolite, which we just don't really use anymore. If you look at this like laundry list of things you have to avoid, you understand maybe why. If you have a patient that's doing well on it and benefits from it, awesome. But a lot of patients will just stop taking it when they want to drink. It doesn't reduce the cravings. It doesn't address the root cause. But if they had a support person that was going to watch them take it every day and could support them, and that was really important to them, I wouldn't stand in the way of prescribing it if their liver functions was okay. Acamprosate or Campril, it's best for maintaining abstinence for patients who have already quit. It may be helpful after relapse. It is kind of tricky because it usually requires that 3 times a day dosing, and patients tend to miss the middle dose there, but it appears to work by stabilizing the glutamate and GABA that are maybe contributing to their drinking. Tovamax, I realize I have 1 minute left, so I'm trying to go super fast here. Tovamax, it's a seizure medicine we also use for bipolar, but it's off-label for AUD. Alcohol use disorders can also be helpful for cocaine or stimulant use disorder. There's some tidbits about dosing and so on and so forth. Gabapentin, I read somewhere, I don't know if it's true, but that 1% of gabapentin prescriptions are FDA approved and everything else is off label. We know it really well. We see our patients really like it in terms of it helping with their anxiety, but it has also been proven to reduce cravings and ease the withdrawal symptoms for alcohol. It kind of works in the GABA, kind of like benzodiazepines, which would be a great topic for another presentation. Adual has a trial in progress. It's a company out of one of the Carolinas, maybe Virginia, where they're looking at how their medication would act on the 5-HT3 pathway, which is thought to reduce alcohol cravings. These patients would have like a genetic test to see if they have a certain mutation, and then would take ondansetron, which, if you're not familiar, is Zofran, but at a very low dose. and that's supposedly going to help them not drink, which would be great. And then cannabis use disorder, there's not a lot for pharmacological interventions yet. They had tried to kind of do like a Narcan version for the cannabinoid receptors, but the side effects were too bad. And then I just want to end with a plug for TMS. Sorry, there wasn't any time for discussions. I'm glad you guys chimed in when you did. And I'm sorry again that this wasn't approved for CMEs. But Michael, if you're still here, I look forward to you stepping up to do a presentation. Sounds like you have a lot to share and you can fill in the gaps that are left open. Thank you.